Ever find yourself wondering if those complaints of gritty eyes from your migraine patients might be, more than just a coincidence?
Uh-huh.
Today, we're diving deep into a pretty fascinating study that explores just that connection. A real eye-opener, if you will.
We are. We're looking at the relationship between dry eye disease and migraine. Specifically, can something as basic as ocular lubrication actually impact migraine severity for people who have both?
Yeah, it sounds almost too simple, doesn't it? And the research we're unpacking, it's a randomized crossover trial. It was published in Optometry and Vision Science, April 2025.
That's the one.
And just so you know, if you want to dig into the details yourself, there's a link to the study right there in the podcast description.
Good point.
So our mission today, really, for all you eye doctors listening, is to understand the clinical side of this. Could treating dry eye actually help your migraine patients? Maybe offer a straightforward way to, lessen their burden a bit?
That's the core question.
Two of us are going to unpack this. So let's start at the beginning. What even suggests these two seemingly separate issues might be linked?
Well, it's interesting because there's actually quite a strong association seen between migraine and dry eye syndrome. Not just anecdotally, but in studies.
Like, how common is it?
Some reports suggest, somewhere between 14% and maybe 22% prevalence of dry eye disease, specifically in people with migraine.
Okay, so not insignificant.
Not at all. And it's more than just them happening together. It's also about the shared clinical features. It gets a bit murky sometimes.
Murky how? You mean the symptoms overlap?
Exactly. Beyond just the gritty, burning feeling of dry eye, patients with both often report things like blurred vision or vision that fluctuates, increased light sensitivity, photophobia, eye pain, even pain around the eyes, like periorbital pain.
Right. And those could easily sound like migraine symptoms or aura.
Precisely.
Yeah.
It can make it tough sometimes to tease apart what's causing what. Is it the migraine? Is it the dry eye? Or both feeding into each other?
Okay, so the symptoms overlap. Is there a biological reason, like a mechanism that might connect them?
That's where it gets really interesting, biologically speaking. The thinking is that both conditions involve the trigeminal vascular system.
Okay, the trigeminal nerve.
Right. And specifically, there's this neuropeptide calcitonin gene-related peptide, CGRP. You hear a lot about it with migraines now.
The CGRP inhibitors.
Exactly. Well, CGRP, released from the ophthalmic branch, that's the V1 division of the trigeminal nerve, seems to be involved in activating pain pathways in both conditions.
Ah, okay. So CGRP is kind of a common denominator here for the pain.
It seems to be a key player, yes. And it likely does more than just signal pain. It's also thought to trigger the release of pro-inflammatory substances.
Leading to inflammation.
Neuroinflammation, yeah, which can then make that whole trigeminal vascular system even more sensitive, sort of a vicious cycle.
Okay, so trigeminal nerve, CGRP, pain, and inflammation, potentially affecting both the head and the eye surface. Makes sense.
And remember, the cornea itself is packed, just densely innervated by nerve fibers from that same V1 division.
Right.
These fibers are constantly interacting with the tear film. And importantly, these corneal nerves also express CGRP.
So if the tear film is unstable, like in dry eye disease,
Yeah.
what happens with those nerves and their CGRP?
Well, the hypothesis, the idea underpinning this study, is that the unhealthy ocular surface environment in dry eye leads to this kind of low-grade neurogenic inflammation
Okay.
and sensitization of those corneal nerves. That's what causes many of the typical dry eye symptoms, the pain, the irritation.
Right. So the study basically asked, okay, if we treat the dry eye, maybe calm down that corneal nerve irritation, could that somehow, quiet things down enough to lessen migraine severity too?
That's exactly the hypothesis they tested. Could reducing the neuroinflammation and stress on corneal nerves, just by improving the ocular surface, actually decrease migraine severity?
Okay, fascinating idea. So how did they set up the study to test this? What was the design?
They used a really robust design, a randomized, double-masked crossover trial.
Okay, break that down a bit. Randomized, double mask.
Right. So randomized means participants were assigned by chance to which treatment they got first. Double mask means neither the participants nor the researchers knew who was getting which treatment at any given time, avoids bias.
Got it. And crossover.
Crossover means each participant acted as their own control. They received both treatments, just at different times.
Ah, okay. How many people were involved?
They had 24 participants. And crucially, all of them had diagnoses of both migraine, could be episodic or chronic, and dry eye disease.
Right. So the specific population they wanted to study, what were the treatments being compared?
2 arms. One was sustained hydration UD. Those are preservative-free lubricating drops. The other was simple saline eye drops, also preservative-free.
And how often did they use them?
4 times a day for 4 weeks for each treatment period.
Okay, sustained for 4 weeks, saline for 4 weeks, but not back-to-back.
No, very importantly, there was a 2-week washout period in between the 2 treatments
Why the washout?
to minimize any carryover effects. You want to make sure the effects of the first drop are gone before they start the second one, so you're measuring the effect of each drop cleanly.
Makes sense. So everyone gets both treatments, order is random, nobody knows which is which until the end. How did they actually measure if the migraines got better?
They primarily used 2 well-known questionnaires, the Headache Impact Test 6, the HIT-6,
Common one.
and the Migraine Disability Assessment, or MIDAS. Both look at how migraines impact life.
Okay. And for the dry eye part, how do they track that?
They used a whole battery of tests. For symptoms, they used the Ocular Surface Disease Index, OSDI, and the Dry Eye Questionnaire 5, the DEQ-5.
Standard symptom scores?
Yep. And then for signs, they looked at tear breakup time, tear osmolarity, and also corneal surface staining looking for damage.
Okay, pretty comprehensive. And they measured all this when?
At the very beginning baseline, and then again after each 4-week treatment period.
All right, solid design. So the big question, what did they find? Did lubricating the eyes actually help the headaches?
Well, yes, actually. The headline finding was that ocular lubrication, and this was true for both sustained hydration UD and the saline, was associated with a significant reduction in migraine severity.
Significant how? Based on which measure?
Based on the HIT-6 scores. The average HIT-6 score decreased by 3.0 points with sustained hydration UD,
Okay.
and by 3.9 points with saline. And both of those drops were statistically significant, with p-values well below 0.05.
Wow, so roughly a 3 to 4 point drop on the HIT-6 just from using eye drops 4 times a day.
Exactly. These results really make you see the potential connection, don't they?
They certainly do. I mean, a 3-point drop on HIT-6 isn't trivial for patients, right? That can reflect a noticeable difference.
Absolutely. It often translates to a meaningful improvement in how much headache is impacting their daily life.
Okay, so HIT-6 showed improvement. What about MIDAS, the other migraine questionnaire?
That was interesting. The MIDAS scores did show a trend towards improvement. They went down a bit, but the change didn't actually reach statistical significance. The p-value was above 0.08.
Okay. So one measure showed significant improvement, the other showed a trend. What about the dry eye itself? Did the drops help that, as you'd expect?
Oh, yes. Big improvements there. Both treatments led to significant reductions in dry eye symptoms based on both OSDI and DEQ-5 scores.
Okay.
And they also saw significant improvement in the objective sign of corneal staining with both treatments.
So the eyes felt better and looked better on staining. Do you have the numbers on those?
I do. Let's see. With sustained hydration UD, OSDI dropped by about 8.3 points, DEQ-5 by 2.1 points, and staining improved by 2.2 grades.
Okay, decent changes.
And with saline, OSDI dropped 6.4 points, DEQ-5 by 1.5, and staining by 1.5 grades. All statistically significant improvements compared to baseline.
So clear benefits for the dry eye with both types of drops.
Definitely.
And both associated with less headache impact on the HIT-6. Were there any things that didn't change significantly?
Yes, a couple of things. Interestingly, they didn't find significant changes in tear osmolarity or tear breakup time with either treatment over the 4 weeks.
Okay.
And also, they did an exploratory measure looking at CGRP levels in the tears. Those didn't show a significant change either.
Okay, CGRP and tears didn't change. And did it matter which drop they used first?
Nope. The treatment order didn't seem to affect the outcomes.
All right. So we've got lubrication, improving dry eye symptoms and signs, and also reducing migraine impact on the HIT-6, but maybe not MIDAS, and not changing osmolarity, TBUT, or tear CGRP in this time frame. Let's try to unpack that. Why might this be happening?
Well, the likely mechanism, as the authors suggest, revolves around reducing that peripheral neuroinflammation we talked about earlier, in those shared trigeminal pathways.
So lubricating the eye, it stabilizes the tear film.
Essentially, yes. It helps restore a bit of homeostasis to the ocular surface. This protects those sensitive corneal nerves from the constant little injuries or stresses they experience in dry eye.
And less irritation to the corneal nerves means less inflammation.
Potentially, yes. Less irritation could mean fewer inflammatory signals being generated right there on the ocular surface.
And that reduction in local inflammation then somehow dampens down the signals going up the nerve pathway that contribute to migraine.
That's the thinking. By reducing that peripheral input, that nociceptive drive from the cornea, you might be lowering the overall excitability or activity in the trigeminal vascular system, taking the edge off the migraine trigger or severity.
Okay, that makes sense conceptually. What about the HIT6 versus MIDAS discrepancy? Why significant improvement on one but not the other?
That's a good question. The author speculated it might relate to the different time frames the questionnaires cover. HIT6 focuses on the past 4 weeks, which aligns perfectly with the treatment periods in the study. MIDAS, on the other hand, asks about disability over the past 3 months. So it's possible that 4 weeks of treatment, while enough to impact recent headache frequency or severity captured by HIT6, maybe wasn't long enough to significantly shift the longer-term disability picture measured by MIDAS.
That seems plausible. It takes time for disability levels to change sometimes.
It could also be that the effect size, while significant for HIT6, just wasn't large enough to push the MIDAS score below the significance threshold with this sample size.
Okay. And what about the fact that saline worked pretty much as well as the Sustain product for the migraine outcome? Does that suggest it's just hydration or maybe placebo?
Well, it definitely suggests that basic lubrication and hydration are key components of the effect. Placebo is always a consideration, of course. But the fact that they saw significant improvements in objective signs like corneal staining, alongside the symptom improvements for dry eye, argues against it being purely placebo. It suggests a real physiological effect on the ocular surface. And it's interesting, while there wasn't a statistically significant difference between Sustain and saline for the HIT6, the Sustain Hydration UD did show what the authors called a clinically meaningful improvement in OSDI score from baseline.
Meaning the subjective dry eye relief might have been a bit more pronounced with Sustain for some.
Possibly, yeah. Which, aligns with what we sometimes hear from patients. They might prefer one drop over another, even if the objective signs look similar.
Right. What about the lack of change in osmolarity and tear breakup time? Why wouldn't those improve if the surface is getting better?
Yeah, that's a common question. 4 weeks might get... Dry eye pathophysiology is complex, right? Osmolarity and TBUT can be influenced by underlying inflammation, gland dysfunction, things that might need more targeted or longer-term treatment than just artificial tears.
Okay, so lubrication helps symptoms and staining relatively quickly, but maybe not the underlying tear film metrics in just 4 weeks.
That could be part of it.
And the tear CGRP levels not changing, given the CGRP hypothesis.
Yeah, that was maybe a bit surprising. But they noted it was an exploratory outcome. Measuring CGRP in tears is still relatively new, and levels can fluctuate a lot. Plus, with only 24 participants, the study might not have had enough power to detect a subtle change, if there was one. Or maybe the effect of lubrication isn't primarily mediated by a change in tear CGRP concentration itself, but more by reducing nerve sensitivity despite the CGRP levels. Needs more research, basically.
Fair enough. So, boiling it all down, what are the main clinical takeaways for us, for the eye doctors listening to this?
I think the biggest takeaway is pretty straightforward. Treating dry eye disease, even just with standard ocular lubricants, looks like it could be a genuinely helpful strategy for reducing migraine severity in those patients who have both conditions.
So don't just treat the dry eye in isolation if they also mention headaches.
Exactly. Or conversely, if you have a migraine patient, maybe ask them specifically about dry eye symptoms. It suggests these readily available, generally safe eye drops could offer a dual benefit. It's a relatively simple intervention.
Yeah, it really highlights that connection. It prompts us to consider dry eye in our migraine patients and maybe ask about headaches in our dry eye patients more routinely.
Absolutely. Thinking about the patient more holistically, addressing the ocular surface might, quite literally, help their head feel better too.
This deep dive really has shed some light on that connection. So to quickly recap, the study found that ocular lubrication, both saline and Sustain Hydration UD, significantly reduced migraine severity, measured by HIT6, in people with both dry eye and migraine.
That's the key finding. And for everyone listening, it suggests this simple intervention, just lubricating eye drops, could offer real dual benefits. It encourages us, I think, to look beyond single diagnoses and really consider how these conditions might be interconnected. Maybe keeping the ocular surface happy really can lead to a happier head.
It's definitely food for thought for clinical practice. And again, if you want to read the full study, check out the link in the description. If you found this discussion valuable, maybe even insightful, we'd really appreciate it if you could leave us a 5-star rating.
It helps others find the show. And please do follow the podcast for more deep dives into the latest research impacting eye care.
Absolutely. Until next time, thanks for joining us.